Good afternoon, everybody.
Good afternoon.
Welcome, everyone.
Afternoon.
Thank
Good
you.
afternoon.
Good afternoon.
Good afternoon.
I'll just give a few minutes because I can see some people trying to log in. Just maybe one or two. Okay. Thank you. I will get us started, and I just want to welcome everyone to our event. My name is Miranda Tafumane, and I'm a Director of Nursing in the ICB. Welcome to our Race Equality Week, and we have a topic, Let's Talk event today, and we have a guest speaker, FELICIA KWAKU, and I have with me today co-presenters, and my co-presenters are Diana Belfon, facilitators rather, and Tendai Ndongwe. And you will see them, supporting us as we go through the talk. I just want to encourage us, feel free to keep your camera on, but all microphones will be muted and will be unmuted for question time. We will have a Slido in motion as well, so we'll get a Slido QR code coming up shortly that you'll be able to just screenshot with your phones, and you can utilize the slider to ask any questions as we go on through the session, or questions can also be typed in the chat. So I would encourage us to be respectful as we and professional in our conduct as we ask questions, as we put our comments in the chat, and we'll endeavor to ensure that we and our guest speaker today are able to respond to any questions that we may have. Without wasting much time, I would like to introduce to you Sharon Smitten. Sharon Smitten is our Deputy Director of People in Northamptonshire Integrated Care Board.
Hello, can you hear me?
Yes, I can.
Yes, we can, Rashmi. Welcome.
Well, thank
Yes,
you.
we can.
I just wanted to share, I'm blind, so this thing doesn't, and a lot of people putting through chats and all that, it really interferes with my software, so it really, I can't mute it. So appreciate if there's question either verbally said or because I won't be able to say. So, and also I don't see the presentation or anything. So, it just things. So I'll appreciate if we, rather than chat, if you are to be asking questions and also, the presentation, I can't say anything. So, so I just appreciate just to start one. Thank you.
Thank you, Rashmi.
Every question that is going to be typed or put in the through the QR code will be verbally announced, and all responses will be verbal. And thanks for raising that point. Thank you. So Sharon, over to you.
Thanks, Miranda. Good afternoon, everyone. Wow, look at that photograph. That was obviously taken in the summer. So bright, cheerful. A very warm welcome to you all, and especially to our guest speaker, Dr. FELICIA KWAKU, who is actually joining us from Australia. So thank you, FELICIA, for today. I'm really grateful for you leading our webinar for us whilst you're on this professional visit in Australia. It really is a personal honour for me to introduce you, to meet you today, and for you to start our Integrated Care Northamptonshire's Race Equality Week 2025. In my role, I have oversight of our EDI priorities across the system, and I connect all of our colleagues in spaces such as this so that we can work together. So today's session is really important to me so that we can further support our ICN contribution and commitment to workforce race equality for both our workforce and our population, including all the race health inequalities work that we're doing with our racialised communities to develop a race health inequalities plan across Northamptonshire. Felicia's webinar is entitled Time to Act, and she will be sharing many experiences of her own healthcare professionals that span many aspects of her extensive career. As Felicia sits on many national committees and forums and charities and has an impressive and interesting career biography. Felicia was awarded her OBE for services to nursing during the COVID-19 pandemic and is also an ICN Global Nurse Leadership Initiative Scholar 2023. Her presentation will include experiences during COVID and the impact Time to Act has had on people's lives, her vital work with the government on identifying COVID trends, and her reflections throughout history, war and conflict, bringing this context right up to date for our actions today, locally, nationally and globally. The national theme for Race Equality Week is Every Action Counts. And so as I wrap up now, I just want to encourage you all to think and have this in mind and consider the actions you might take after today's conversation. So without further ado, I really look forward to our webinar, and I will be handing over to Felicia right now. Welcome, Felicia.
Thank you very much, Sharon, and thank you for having me. And I welcome all the participants as well, and Diana for inviting me. So I will make a start. Bear with me, it's very hot where I am in the tropics, so if there are flying things and I'm spotting, just bear with me. So let me start. So thank you, Sharon, for the introduction. Sharon has outlined, I'm going to talk about three particular core issues that I think are really important. And so can we move to my first slide? So no, actually, before we go to the first slide, just a couple of things for us to set the context. So you may be triggered during this presentation because we're talking about COVID, and we know how particularly hard that was. And I worked on the front line across my medical wards, as I know a number of you would have as well. And so that's just a warning for you. I may be controversial. There are some clear facts here, and then there are also some reflections, personal and professional reflections as well. So it's not easy. And I remember, especially during COVID, that many of us, we didn't stop crying for at least 2 years. And at times I may get emotional or I may cry. I hope and I'll be able to hold myself together because it was a very difficult time. So my name is Felicia KWAKU. I am from Nigerian stock. I'm really proud to be a Black woman, a Black nurse. I wear my colour with pride, absolute pride. My parents came over early 60s. My dad sailed on the Elder Dempster shipping line, which was a West African shipping company, and it took him over a month to get here by sea. So he showed great grit and determination to be here, and he passed that legacy on to me, although he's passed away now. And I've always had that sense of responsibility and discipline, because as a black person, as an Asian person, as an ethnic minority person or marginalized community, it's not just about being and wearing your color. It's about the sense of responsibilities that you have to carry your people with you. And that comes with pride, but it also comes with, that responsibility it can be really huge and overwhelming sometimes. So those are the things that kind of made me tick and be very vociferous around racism, discrimination, and justice. So I just put that out there, and I love being a nurse. If you split me open, you'd find nursing running through every core of me. And although this is from a nursing perspective, it can also apply to whether you are a ward clerk, a doctor, in administration, in management, in the various backgrounds. So let us start. So this first slide then is, this is one of the earliest newspaper photographs. I think it's either from the Telegraph or from the Guardian. And this was one of the key indicators at the beginning of COVID that there was something wrong and disproportionate during the COVID-19 pandemic. And when you look at all the people in this picture, you will notice quite immediately that there's a mixed batch of people, but in particular, there is a lot of people of colour. And that was one of the first alarms that things weren't as they should be. And in the second row, the third gentleman to the right is Dr. Alpha Sadhu, and he was my medical director when I was in hospital. And we heard that he passed away very early on, and we couldn't believe it. We were, are you sure this is Alpha? And so that was another reason why some of the issues around COVID drove me and the group to really take seriously some of the issues that came forward during COVID. Next slide, please. So as we were going through the pandemic, this is data that came from, I think it was about May. I think it's around May, April, May. And this was from the Institute of Fiscal Studies, which is the green document. And it clearly started to show emerging findings that there was disproportionate impact of COVID-19 on Black, minority, ethnic communities. I'm not going to use the terminology global majority. I don't like the term because although we are the global majority, we don't hold the power. It doesn't add anything to the power dynamic across the country and the globe. So I'm going to describe the chart for those people that might be sensory impaired, because I think it would be useful. So I have two graphs on this slide. It shows the proportion of nurses and medics and ambulance staff in the National Health Service. Approximately over 40% of doctors are from a Black, minority, ethnic background, and over a quarter, 25%, 26% of nurses and midwives are from a Black and ethnic minority background. And I think for the ambulance staff, it's probably about 2 to 3%, I think. This graph then shows from the Institute of Fiscal Studies, it shows the difference between ethnic minority people and people that are white British in terms of the likelihood of acquiring COVID and the likelihood of death. And this graph was quite stark for me at the beginning of COVID, because it shows that if you are from, it showed at the time that, and this is 2020, that if you were from a Black and Afro-Caribbean background, then the likelihood of death, predicted death from COVID-19 was 3 times more than a white British person. If you were Black African, it was just over 1 times more. If you were Indian background, it was 1.5 times more. Pakistani background, just over 1 times more. So already around April, May 2020, we were starting to see some trends about the disproportionality of the impact of COVID-19. And there were really important documents. Next slide, please. So we also received data from Department of Health and NHS England. And this was data taken in June 2020. And at that time in June, there were 216 NHS staff deaths. I think this was really under-recorded at the time. Most of those deaths at the time were from an inpatient setting, 199, and 17 staff died in the community. This was very underestimated. When they looked at the ranges of staff that had died, you can see there is a whole range. The biggest range were for staff that were in the age range of 56 to 65 and 45 to 55. And that was roughly around 40% in that age range between 56 and 65 years. But one of the stark things that came out with that data is that the largest group of staff was staff from the Black and minority ethnic communities, and that was sitting at 62%. So we knew that there was a problem. And just a note to say that this is the data recorded, particularly from in-hospital deaths of staff. It doesn't account for deaths in primary care. There was no data at the time for primary care or health and social care or the other sectors. So that shows you that there was a paucity of data being recorded. And I remember quite starkly, if you worked in health and social care, the nursing homes, there was no data, and there were a lot of deaths of people in the community. Next slide, please. So why is all of this important? it is important, and there's another graph, and I will talk through the graph. So this slide talks about the graph, and it shows the proportion of white colleagues and colleagues from Black and minority ethnic working groups. It shows the different kinds of banding and then the representation of BME staff compared to white staff. And what's very stark is that as you go up the bands from band 5 to band 9, you'll see that for white staff, they are evenly proportioned across all those different bands. But if you're from a BME background, you will the graph shows that there's overrepresentation of BME staff in band 5. And if you looked at bands 1 to 4, you will see lots of overrepresentation of BME staff there. And then as you progress up the ladder to band 9, the representation of BME staff becomes low. And it's very low in the higher bands, around 8B, 8A and above. It just becomes lower and lower. There is some improvement there, but it's still lower. So at the time, I was chair of the Chief Nursing Officer and the Chief Midwifery Officer's BME Strategic Advisory Group. This is a group that advises the CNO and the Chief Midwifery Officer at the time around matters regarding race equity, policy, protocols, or we liaise directly with staff. And the staff were starting to tell us some really worrying things at the time. And I remember conversing with the regional leads. We have leads across the regions of NHS England. What are we going to do? This is the intelligence that we're hearing on the ground. We need to be able to speak to staff directly. So obviously during lockdown, we couldn't speak to staff. So we arranged a series of webinars across every single NHS region, from North East Yorkshire, Northwest, to the Midlands, to the East of England, to the South East, the Southwest, London. I think I've labelled most of them. I hope I haven't missed any out. There were 7 regions, and we held webinars during April to June. And this gave us an opportunity to directly engage with people online. And it also gave staff a really safe space to express any concerns that they have. And we did 9 telephone conferences. And they were difficult. They were difficult at times because there were a number of really distressed staff on the calls who told us that they were going to die because they just didn't feel that they felt safe and people weren't listening. So we held them, and we spoke to approximately 1,600 staff at the time. Next slide, please. So what did the staff tell us? They told us that this was predominantly for NHS staff, but there were lots of other staff on the call, because when the word gets out, and many other staff who are not nurses or midwives will join the call because it's to do with ethnicity. So we had social workers, physios, lots of AHP staff, predominantly nursing and midwifery, but we also had staff from health and social care and agency nurses. And the agency nurse told us that as agency nurses, they didn't have any rights, they were ignored. They told us that some ward managers were hiding the PPE from them, locking it up. They couldn't have access, and they were expected to work with COVID-19 patients without any PPE or any protection. They said to us that there was a paucity of communication, wrong communication, inaccuracy, or none. Staff felt they were being discriminated against. I remember that there was separate guidance for staff. If you were, for example, 26 weeks pregnant, you can go off and be shielded. But many staff told us that as a member of staff from an ethnic minority background, it didn't apply to them, and they were still being made to work the full term. They wanted information about vitamin D and the COVID-19 etiology itself. A lot of them were very stressed and had post-traumatic stress. They didn't have any psychological input and support. There were also a number of staff telling us that they were failing the fit test, and I'll go into a bit more detail. So the fit test is where the FFP3 mask, which is the best mask to have if you are nursing highly infectious patients, it helps you to have a secure seal and keep out any, if you like, bacteria. And they told us that it wasn't fitting properly, particularly Asian nurses. And the risk assessments were a big problem because if you remember at the time, there was national guidance for all staff within healthcare settings to have risk assessments, and a number of the staff told us that they weren't being risk assessed. And then the other issue, the big issue, was around testing. Big issue around testing. So lots of BME staff said that they weren't getting tested, they weren't rapid and speedy enough. So a number of issues on those calls, and we had to sometimes stop the calls and counsel people because they were very, very distressed. And for those of you who can see the slides, that middle picture is me and my matrons on a Saturday morning during early part of COVID-19, changing wards, converting wards to COVID wards, and trying to plan our days. We basically lived within the hospital at the time. So based on those feedback from the staff, which was really, really useful, there were some key comments that the staff told us, and one, I remember a number of them telling us that they didn't come to work to die, that they didn't feel they could trust the organisation, that this command and control, so remember command and control, where the executives took charge of the way the hospitals and the healthcare systems were running, they just didn't feel included or engaged with. They just didn't want to die, they didn't want to get COVID. There were just so many comments and so many emotions running through those workshops and those webinars. Next slide, please. So once we had listened to everybody, we made a set of recommendations, and there were many, and we tried to streamline those recommendations. And I have to say that I know that many of you will have relatives, friends, colleagues that died. And I remember we were doing these webinars, and my uncle got COVID within a day, and then died. I think got COVID on a Friday, went into the hospital. We couldn't see him, and then on Sunday we got a call in the earliest hour of the morning that he had died. And so when you are working on the wards, on the front line, doing the things that you're meant to be doing, and then your close relative dies, I was, like many of you, really traumatized, and I just didn't know whether it was coming or going. And you say to yourself, how can you continue to do this when your beloved loved one has passed away? So it changes your perspective, and sometimes the resilience that you have just takes a big dip, but you just have to kind of shoulder on, and we had to continue this, because the other stories that we were hearing is that, especially for our people, especially for internationally educated nurses, a number of them had come over into this country on their own, and a number of them died in their rooms or in the nursing homes because they didn't have the contacts, and they were so ill that they couldn't even get to the door. And we heard a number of stories where nurses died where they fell. And so that really propelled us to be absolutely clear about the work that we needed to do around safeguarding the staff. So I'll read out the list of some of the recommendations that we made, and some of them were around, although we were NHS, we needed to liaise with the agency nurses who are part of the work structure to ensure that they had also the safeguards and protection that NHS nurses had as well. We said it's really important for directors of nursing and the executive teams to really engage with staff, tell them what's going on, ensure that help them ensure that their staff feel safe, and put safety processes in place. I think it was really important to ensure that staff could speak out, and they needed really good information around vitamin D, nutrition, exercise, shielding, sleeping patterns, so many things. We said the Freedom to Speak Up Guardians need to be really diverse. At that time in 2020, the first report from the Freedom to Speak Up Guardians from the NHS, 80% of Freedom to Speak Up Guardians were white. Well, if you've got a quarter of BME staff within the system, you need to make sure that you have representation there. You have to design services that meet the needs, and also people that look like you, because you can be putting up lots of services up, but if staff cannot talk to people that you feel look like them, understand them from a cultural perspective, it's good for nothing. So we recommended that. We also produced a weekly bulletin, furnishing staff with lots of information, And at that time, we found out that there were bespoke services for BME staff, especially externally as well. And we also clearly needed to do further webinars to provide further information. And mental health services were really important. So that's a whole range of recommendations that we made, and we put that into a report, and we formally submitted that into NHS England, into the Chief Nursing Officer at the time, who's Dame Ruth May. And based on all those recommendations, there was an inaugural CNO BME action plan across the whole of England. It's the first ever action plan bespoke for BME nursing and midwifery staff, and there were 5 work streams. And our work as the CNO BME Strategic Advisory Group directly informed that plan. So it's a great sense of achievement. And so those 5 work streams were around protecting staff, engagement of staff, representation, sorry, I'm just trying to see, representation, rehab and recovery, and communications and media. Very, very proud of that work. And that meant that across every single NHS region, all the regions were held to account for those 5 work streams, particularly for BME staff. Next slide, please. So this is the group. This is the CNO BME Strategic Advisory Group, the Chief Nursing Officers Black Minority Ethnic Strategic Advisory Group. At the time, there were probably about 12 of us at the time doing this work across England. Really, our focus for that year, for 2020-21, was all around COVID-19. And that work also dovetailed into the vaccination campaigns, some of the mythology that was coming out across the press and the media around COVID-19 itself. The work also involved us working with Baroness Lawrence, that's Stephen Lawrence's mother, who also carried out a Labour inquiry around COVID-19 and disproportionality. So we met with her, had a round table. We met also with Professor Whitty, who was the Chief Medical Officer at the time. He met with a number of us so he could listen to us from a BME perspective about the concerns we had about disproportionality and the health inequalities. We also co-opted epidemiologists that could give the scientific background to COVID, so that all those kind of mythologies were really clearly explained. And in total, we probably liaised and engaged with probably about 3 to 4,000 staff. So, you know, it was really impactful work that we are very, very proud of. Next slide, please. So I'm just going to outline, this is the Chief Nursing Officer and Chief Midwifery Officer's Ethnic Strategic Advisory Group. And our job really is to influence the voices of nurses and midwives from BME backgrounds at a national level. And we provide a specific race equality perspective. And it's really important to focus on race. When we often talk about other characteristics, whether they be gender, sexuality, pregnancy, age, religion, all those kind of things, sometimes the issue around race is always put in the difficult to do box. You know, it makes me absolutely frustrated that the race is too difficult to do. That even the word race is a social construct. But we need to focus on that. And if you get the race equality right, then it sets the marker for getting equality around all the other 9 protected characteristics. Get that right. As a person of color, we can, as a person, you can't hide your color, but you can hide your sexuality, you can hide your age, you can hide some of the other perspectives. But when you walk into a room, your color is the first thing that people see. So if we can let's focus on that. It's not difficult. It is not difficult. Let's be honest and open, and just be really engaged about this agenda. So that's us as a group. We've been in existence in 2001. And at the time, we were the only advisory group to the Chief Nursing Officer and the Chief Midwifery Officer of England. Now we have a few more, which is really encouraging to see. We have the Jabali, which is the men's BME group. We have the BME Dons, Anola Ishmael, Chief Nurses Group. We have ourselves, and then we have the Ethnic Minority Collaborative, which is all of us together advising the CNO and the CMIDO. Next slide, please. So as I come to the end portion of the pandemic part, I just really wanted to talk about the second wave. So that first wave was difficult because because of the confusion to wear masks, not to wear masks. I remember right at the beginning, the high number of deaths amongst the population and particularly the staff as well. In the second wave, I think people's resilience was a bit knocked because, you've gone through the first wave, it was pretty terrible, and then you have a second wave. And so what we saw in the second wave was the speed of spread was much faster, the death rate was higher, although they learned not to mechanically ventilate people in the second wave. Otherwise, once you put people on the mechanical ventilator, it's very difficult to wean them off. We started having all those variants in the second wave, and staff were just really exhausted. Health and wellbeing was really impacted, and there was a high load on staff sickness, whatever the discipline was. And nurses and health workers were still dying at a reduced rate, but they were still dying. And I remember on this slide, on this slide, there is some pictures of the healthcare workers that died. And they compared some of the stats from the COVID-19, the related deaths, they compared them to some of the kind of deaths in the war. And some of the fatalities during COVID-19 are comparable with times of conflict. So it was quite appalling. And I think the system needs to do more to protect the public as well as the staff. In this slide, there's a mention of me. There's a number of us that got recognised in the King's Honours, in the Queen's Honours at the time. And although I was really proud, and a lot of us were proud, I was always tinged with a sense of sadness because, it's good to be recognised, but there was so much death, and there was so much death of our colleagues and people that we knew. And there's a strip of nurses at the bottom of this slide. I think there was about 11. And I remember I was an anti-vaccine person. I was not having that vaccine. My whole family, we were just not going to have it. And I remember it was the second or third week of January. The vaccine, I think, had just come out, maybe in November, December of the preceding year. And I was counting a lot of the deaths. Remember that a lot of the deaths were unreported, but we kept a tally of the nursing midwives' deaths. And I remember getting lots of calls from the CEO, the president, of the CEO of the Royal College of Nursing, and Yvonne Coghill, asking me, Felicia, what numbers do you have? Because we were keeping them locally and people were reporting them to us. And there's that strip of nurses, and it was the third week of January. And I counted about 12 nurses died in 1 week. 12 nurses. And when I looked at the backgrounds, at least 7 or 8 of them were from a Black and minority ethnic background. And I just said to myself, Alicia, that can't be you. Yeah, that just can't be you. We've already lost my uncle and I took my vaccine. And so there's so many points of change, of realization, of drama, of hurt, of pain, of optimism during that COVID-19 pandemic. But it was a very, very difficult time. So as I come to a close of this particular part of my presentation, the next slide, please. I think one of the seminal points of this work that we've done was around the masks. So remember I mentioned earlier that there were issues around the mask in terms of staff telling us that the mask didn't fit. And I remember having a conversation with Sue Tranker, who was the one of the deputy chief nurses at the time, and she said to me, Felicia, what's all this communication coming about the mask? And I said, well, a number of staff are telling us that they're failing their fit test because the masks don't fit. And then you dig deeper and you find that FFP3 masks are modelled and designed on a white male. So if you have different features, because we come from a whole range of backgrounds, if you have a smaller nose, a smaller jaw, you may not fit that mask very well. So can you imagine lots of nurses and other healthcare workers, they can't fit the FFP3, and then we're expected to go out into a COVID-19 environment. So this is the conversation I had with Sue Tranker at the moment, who's the chief nurse of Wales. And based on the information that we gave her, she commissioned a specific trial on kind of nose to jaw measurements. So she did this rapid trial across England, and based on the findings of those trials, they redesigned the FFP3 mask, and they redesigned 6 new masks. And so that was as a direct result of the engagement with staff and what they were telling us and feeding us with intelligence around the facial fittings. And we were really, really proud of that. That was 5,557 staff that participated in that trial. It was absolutely seminal and a life changer. So that's the part on COVID. Diana, if you wouldn't mind moving on the slide, please. And hopefully this presentation will be available for you. So I'm going to come to now the workforce and really around ethnicity. And this frustrates me a lot because this is really around the proportionality of people from different BME backgrounds, but particularly around representation. I'm very passionate about equality and diversity, but particular race equality. So as I mentioned before, 40% of our doctors come from a BME background, and about 26% of nurses and midwives come from a BME background. And you will know that there are over 200 nationalities within the NHS and across the primary healthcare system, health and social care, and the independent sector. So we are a mixed bag of people, but this data focuses on the workforce race equality standard produced by NHS England. And so on the left-hand side of this graph is the BME representation. On the right-hand side is the white representation. And it looks at the representation between 2018 and 2023. And you'll see year on that the percentage of staff from BME background is increasing every single year. And the data from March 2023 is that 26.4% of the workforce across NHS trusts come from a BME background, which is around 380,000 people. So in 2018, the percentage was 19.1%, and in 2023, it's gone up to 26.4%. And I have to say, probably the majority of that growth is from international recruitment, especially nursing and midwifery. Since 2018, we've probably recruited internationally well over 60,000, approximately 65,000 internationally educated nurses. So it's huge, absolutely huge. In this slide as well, if we look at the Nursing Midwifery Council, which is the nursing midwifery regulator, in the last 6 months, there's been an increase of 14,949 nurses, percentage, which equates to, an increase of 14,949, which is an increase of plus 1.8% of 841,000. And most of those, that increase, 45.9% of the new joiners were educated outside of the UK. So the top 5 countries for nurses and midwives are India, the Philippines, Nigeria, Romania, and Ghana. And just to say, remember, Nigeria and Ghana are on the red list, and the other country, Romania, I'm not sure, but I know Romania is within the list, and India and Philippines are on the green list. So we rely heavily in this country on international migration and recruitment from a whole range of healthcare disciplines. Without the contribution of people from BME backgrounds and the Commonwealth, etc., the NHS would not exist in the way it does today. And so it's important to get that equality and equity piece right. Next slide, please. So we recognise that there is racism and discrimination within the National Health Service. I don't think anybody can deny that. And there are drivers. We have, of course, the legislation from 2010. And then within the NHS, we worked with the regulators, the NMC and the NHS Confederation to produce a toolkit, an anti-racism resource framework. Really, really important work to guide people around how to address issues of racism and discrimination within the workplace, how to create sense of belonging. We have the long-term workforce plan, which focuses on race. There's a race discriminate equity element in there. And then we have the EDI, Equality Diversity Improvement Plan from NHS England, which focuses on high impact action with race equality in there. So we know there's an issue because we have report upon report upon report. So why do we have to keep on doing reports? It's because we have only small improvements. There's always a blockage. Remember, we have decades and centuries of issues around race, from the Darwin's evolution and theories around race, and setting the scene for people of colour and gender to be inferior to other races. So it starts from centuries, and it's going to take centuries to combat. But we continue to produce data so that nobody can argue that this isn't a real problem. And on the right-hand corner of my slide, so we have the BRAP report that was produced by Roger Klein and Joy Warmington last year. And then we have Michelle Cox on my bottom right-hand screen, who took NHS England to Employment Tribunal. Took her 3 years, and she won her case. It's a landmark victory. So how do we act in these spaces? We act by ensuring that people are aware of legislation and tools. And Michelle Cox was one of the members of the CNOBME Strategic Advisory Group. She was one of the leads for North, and still that didn't protect her. So we made sure, in terms of acting, to provide really good pastoral care for her. And myself and Joan Myers, we actually attended the tribunal. This has been a real wake-up call for the NHS, and I think other systems as well. And one of the disturbing things at the tribunal was the NHS lawyer that was employed to defend that particular part of England, and they were absolutely appalling in their behaviours. And so what do we do in acting is we make sure that we can buffer Michelle and those similar to her, and make sure that they've got the right representation, guide them, steer them. And when that report came out, I, in my role at the time, made sure that the CNO knew, and made sure that the relevant parties across the country knew, and we held an emergency extraordinary meeting as a SAG group to check in with staff across the country, because there was lots of anger, frustration, lots of tears and triggering with this case. But it's landmark, and it's our duty to make sure that we spread the messages about the learning from that case. And the judge was phenomenal, very clear about the responsibility and the disgraceful behaviour of that organisation. Next slide, please. So I talked about internationally educated nurses and midwives or other healthcare workers. Shari mentioned at the front that I'm a scholar for the International Council of Nurses. In our project last year, we did a work on labour agreements. Labour agreements are really important. I'll just touch on it very quickly, because lots of these labour agreements on bringing people into England and other Western countries, they're done behind backroom doors. Sometimes there's no health person in those contracts, and it's really important for us to be able to be in those spaces where, whatever your discipline is, but for us nurses and midwives, we need to be at the table when those negotiations are happening. And because if we're not, then we find exploitation of workers, and we hear things like internationally educated nurses being housed in caravans, recruitment agencies exploiting them in terms of money, and some people being trafficked. So this is not a joke. This is real problems around safeguarding workers that come, staff and individuals and their families that come into this country. So we chose this particular topic. We produced it is shocking, yeah. We produced a paper, a literature review, and that literature review around labour agreements and what we think is best practice has gone to the WHO Euro region, representing the Euro region as evidence within the portfolio for the International Code of Practice in International Recruitment. That's how we act, yeah? That's how we change things, yeah? That's how we get the voices of us as BME people at the table. So I'm really proud of that work. Next slide, please. And sorry, and the other way we work is I was at European Parliament last year as well around emergency preparedness. And it's also important that in terms of emergency preparedness, how do we learn the lessons of COVID and other emergencies? How do we learn them? And who's at the table when they're making decisions around us? And I was able to attend European Parliament at this colloquialism around multidisciplinary learning and education of emergency preparedness. And I was the only nurse that's actually active in clinical duty at the table. I was so proud to be there, and I'm a Black nurse and the only Black nurse there in European Parliament. So this is not just for me showboating. This is that any of us can be at those tables, any of us. Okay, we need to be in those spaces. Often people of colour, we're not in the spaces, or we're not visible. We have to be out there in the media outlets, on social media, etc., etc. It's really important. Next slide, please. So as we continue during my presentation, I am conscious of time. I'll speed up very quickly. Just to talk about our history in this country, whether you're Asian, whether you're Black, we have the Windrush history, but we have nurses here and Black nurses here in 1850. And you will see on my slide presentation, Annie Brewster, she came from St. Vincent to London in 1860. So it's just a reminder that we have a history in this country. Our blood, okay, don't rush. Our blood runs through the veins of the Commonwealth, of England, United Kingdom. We have a rightful place here amongst the discrimination and everything else. We have a history from the emperor in the Black emperor in Roman times here to, Black pilots, Black military in the war. You never hear about those things, but we have a solid history in this country and we need to be able to recognize it. And there's a second picture on my slide, which is a Black nurse. We don't know what her name was, but she was photographed in the war nursing the wounded soldiers. So once again, a history, not just in this century, but in the previous century as well. And we have, Commonwealth staff coming from the Philippines, from India, a real great history here. And we shouldn't forget that. Next slide, please. So are there signs of improvements? Yes, there are. They're small and they need to be much, much bigger. And on this slide is a picture of, I think, some of the greats and some of the emerging Black, Asian, ethnic minority nurse leaders, phenomenal people in their own right. And this is the beginnings of a catalogue of history of BME leaders. We have them there. We need to big them up and we need to be fostering and looking after the generation to come. And on this slide, you will see Mary Seacole Sutranka, the first BME nurse of Wales. She's phenomenal. We have Jacqueline Dunkley Benn, who was the first chief midwifery officer of England and is now the most powerful chief midwife in the world. That's it. She's the International Confederation of Midwives chief midwife. Yvonne Coggill's there. Wendy Ole-Waller, the ethnic minority lead nurse and midwife at NHS England. Dame Donna Kinnair, who was the CEO of the Royal College of Nursing. Dame Donna was the spokeswoman during the COVID-19. That's where you saw her in Question Time, speaking up for nurses, on the phone to me all the time during the COVID-19 pandemic. Dame Elizabeth Annie Onwu, Michelle Cox, our hero. Let me be clear, absolute hero. And we have Francis Fernando, and we have Francis Fernando, absolute stalwart and champion for Filipino nurses, and Tracy Jolliffe, previously from the NHS Leadership Academy. I also put on this slide pictures from the ward. This is a couple of pictures from the ward during COVID. They are also our heroes and our heroines when we had to really fight to stay sane, but also changing wards from normal wards to COVID wards, scared of getting COVID yourself. I always say during COVID-19, I saw the best of the NHS and I saw the worst of the NHS. We need to be clear about that. There was a lot of fear. Next slide, please. So I talked about green shoots. So we have some green shoots. We don't, The numbers of BME chief nurses and chief midwives is very low. It's too low, probably less than 20. People, BME nurses and midwives are 8B and above, probably over 200 now, still insufficient. And I know I've mentioned around the toolkits, the legislation, the guidance, it's just not enough really. We need to keep on pushing the dial. So we have some more people. I'm going to name check them. You need to look them up. Adi Bhatia, she's the chief nurse of Guy's and St Thomas's in London. She's from an Asian background. Karen Bonner, she's the first Black BME chief nurse of an NHS region. No, actually, sorry, of London, because we have a Kosi and Yanin as well, so of London. So, loads and loads. Asha Day, we have Oliver Soriano, we have Kosia and Yanin, she's one of the Deputy Chief Nurses of England. We've just had the first Asian Royal College of Nursing President, Sheila Sobrani, Rohit Sagu, doing phenomenal faith work in the community for the Sikh community. And we have Professor Calvin Morley, a dynamite lecturer and academic. And we have Jenny Kagiwa, the first nurse at NHS England for ethnic minorities, really with a mandate there. So it's happening, it's slow. I would say it's still not enough, but we're getting there. Next slide, please. Next slide, please. So I've talked about the voice of nursing. It's important that we do have a voice and a space there, because our business is around health and protecting and looking after patients, absolutely integral to the work that we do. And we need to make sure that our voices are there at the table in terms of policy, that we have a real fit for purpose workforce, that we are paid and recognised well, and that we have a voice, whether it's lobbying ministers, your local authority, your ICB, or your region. It's really, really important. And I think we as BME people need to be really, really visible. Next slide, please. And this is what success looks like. So this is the CNO BME SAG. This is at the end of 2022 when I did the report. This is about what recognition looks like, what some excellent looks like. It's not the whole story, but this is what excellent looks like. And we publish this, we showcase it on social media so that they can see us. They can see us. This is what excellent practice, knowledge, intelligent looks like. And you'll see regional leads like Sandra Jackson. We have Rukaya from Northeastern Yorkshire, Jennifer Pearson from this region, the Midlands region, doing phenomenal work. And Jennifer did fantastic work during the pandemic, especially working with communities as well. And Rukaya does phenomenal work in Northeastern Yorkshire around midwifery, maternity, making sure our work is out there. And we've been recognised by the Health Service Journal. Next slide, please. So now this is the final part of my presentation, and really it's my reflections and really just to get people to think about conflict and war. And this is really, really important because the world is changing, and healthcare plays a real important part in terms of conflict and in war. So this is the armed conflict location and event data. And it's a data collection analysis of crises that are happening across the globe. And it collects particular information around healthcare workers. And it looks at dates, locations, fatalities, and the trends in conflict. And on that list, there's about 50 countries on that list. So everybody's very focused on Palestine and on Syria and the Ukraine. But there's at least 50 countries on this list. And it's just to remind you that there are more countries around, including Myanmar, Mexico, parts of Nigeria, Brazil, Colombia, South Sudan. The Congo is very topical at the moment as well because of slavery and of conflict, Pakistan. So it's just to put the consciousness that there are many other areas across the world that have conflict. And in January of last year, there were 10 high-level countries, and Palestine was deemed the most dangerous place in the world. The previous time period it was the Ukraine. Next slide, please. Okay. So this is also data from Insecurity Insights. And basically on this map, it shows you the particular places across the world where healthcare staff are either attacked, threatened, or killed. And in war and conflict, what's been increasingly noticeable is that healthcare staff and healthcare facilities are targeted purposely by the warring factions and parties. And there is data collected to show us where this happens. And in 2023, there was documented over 2,500 episodes of violence and death and incidents amongst healthcare staff. And this happened in over 30 countries. And between 2023 and 2024, this relates to a 25% increase. Sorry, since 2020, a 25% increase in these occurrences. So the world is unstable at the moment, and healthcare staff are particularly very vulnerable in these times. Next slide, please. So why is it important? Because many of us across in this country and across the globe may want to help. And okay, thank you, Felicia. May want to help and go and offer assistance in these areas. And so I think I just really want to say that people need to be clear about what their role is when they're maybe going into these countries if they want to help. And they also need to know that it's not just about helping people at the time of war, it's also what happens afterwards when war has finished, and being clear about our roles and the conscience that we have as healthcare workers as well. Next slide, please. And so it's difficult for healthcare workers. They're trying to do their they're trying to do their work in really difficult conditions. They may be the only healthcare people there. A nurse might be the only healthcare person there, or a midwife might be the only healthcare. And you're constantly being threatened and under attack in these really, really difficult conditions, and especially when their actual health facilities are being destroyed. Next slide, please. So this might be a tough slide for people, but this is really about Myanmar, a very vulnerable place at the moment. And in 2021, the junta army rejected democratic processes after the election in 2021, and they closed down the social fabric of the country. That means all hospitals, universities, and doctors and nurses and other healthcare workers were put on the death list. And a lot of nurses fled to work in the villages. A lot of doctors have fled to work in the villages and the refugee camps. And there are hidden jungle hospitals. But what I wanted to say really is that, healthcare workers continue to be targeted, especially nurses in Myanmar. And this is Lisa. And Lisa was captured, tortured, and murdered in Myanmar. And the only reason why they found her was because some of her remains were found buried, and that's the only reason why they found her. So absolutely shocking. But we are here in the UK, and there are people doing the same jobs as we are under the threat of death, torture, and very, very difficult persecution. And I just wanted to remind people about that, because this is the reality for many, many people in other countries. Next slide, please. So some of us are trying to help in those countries. We're doing medical missions. We are going out into the jungles, into the hidden camps, to try and improve education, provide pastoral care, and share experience and learning and education in very, very difficult circumstances. And this is an example of an education training camp in Myanmar. I can't tell you who my colleagues are because of the perceived threats, but doing really, really good work in there. And just to remind people that a lot of these conflicts are in conflicts where they are low and middle income countries, people that look like me and you in many of those countries. Next slide, please. So to say that, nurses and midwives doing fantastic work in these areas of conflict, delivering really great care and really putting themselves, sometimes their lives, their mental and physical health on the line, delivering care in secret. delivering really, really good care. And I think it's created opportunities and platforms for people to do care in very innovative ways. Sometimes the West can think that when we're going over to those countries, we are the be-all and end-all, when actually those countries are doing some really, really innovative things that we wouldn't even think of or be doing in Western societies. So once again, just to make sure that nursing midwifery needs to be in those spaces, having a voice in policy, caring for people, caring for family and relatives, and not to forget that although we might be United Kingdom, people also here suffer from vicarious trauma. And we're doing some work with some of our internationally educated nurses who suffer from vicarious trauma because they've got relative families in those warring countries. Next slide, please. So this is my last slide. So I'm here in Australia. I've come, this is a mixed visit for family, friends, and also as a scholar, GNLI, ICN scholar, is to tap into the healthcare system while I'm here. And I'm very struck that with this race equality week and every action counts, that, you know, although I'm doing the leisure things, there are other things that I need to do in terms of actions. And I have spent some time with the Aboriginal First Nation communities in Palm Island, which is an island in Queensland. The Aboriginal communities aren't treated always very well here, and it really resonated with me. Their struggle for their land, their struggle for their ancestry and history, and being recognised with people from BME backgrounds here in England, in the United Kingdom, and across where we are in spaces where we are the minority, we are also struggling. And it really resonated with me, the fight for Aboriginal communities and the recognition of First Nations. And we've visited some healthcare centres everywhere, most places, even health facilities, buildings, Aboriginal paintings and art are threaded through all the lands. They may not have the same rights, but it's threaded through, and they acknowledge that with testaments. We don't do that in the United Kingdom. We have to constantly fight for recognition. You know, even in adverts on telly, you ever rarely see an Asian family or a Black family. It's you know, this thing about that visibility is really important, about representation and about the struggle. So those are the things that really touched me in this visit. And in the bottom right hand is a group of us, and Professor Lenore is in a blue shirt. She's a professor of one of the few here in Australia of nursing midwifery, and we were talking, and she said, you know, when I leave the island, and I come back, I have to reset myself for going back into my community again, because she thinks about the inequalities and the injustice. And sometimes we, as people of colour, we also have to reset ourselves when we have to constantly fight discrimination, racism. We are constantly battling. And for those of you who are not in our shoes, it's really important that you recognise that, and that we all do collectively to make sure that we can get that equality, equity right for all, but specifically for BME communities. That's the thing about your action. Every action counts, whether you speak, whether you do, whether you think, is absolutely important. And this mural behind me is around, it's by Lenice, by Lenice. She's an Aboriginal artist, and this image describes the concepts of Aboriginal peoples, First Nation peoples, accessing health. It's a sense of community. It's a sense of collaboration, and it describes abundance as well, and their legacy. And we as people of colour also need to cement that legacy here in the United Kingdom. So I think I will stop there. Thank you very, very much. Thank you.
Thank you, Felicia. Thank you. Okay, thanks for taking the slides. We've got a gallery view now. I don't know how that's happened. Okay, let's get everyone back. I'll spotlight on Felicia. Great. Thank you. That was so interesting. We've had some comments. I think everyone was, we didn't have many questions come through, Felicia. Personally, I was gripped throughout that listening to your presentation, which was extremely thought-provoking. Thank you. I'd like to ask people if they'd like to ask any questions now. Rashmi's put his hand up already. We can do that through the chat box, continue through the chat. We put the Slido link if people scroll up to the top of the chat, and obviously people can raise their hands. But are you comfortable to take some questions now from everyone?
Yeah. I'm just going to switch to see if you can hear me from the PC. So just bear with me.
Yeah, we will do.
Sharon, just to note that we have some questions already that have come through Slido, and Diana will be able to push those through, or we'll send them to you.
Lovely, thank you. Thanks, Miranda. Okay. You're on mute, Felicia, but can you hear us?
Can you hear me?
Yeah, I can.
Yeah, I'll stay on the phone.
Lovely.
I'm just going to plug in. So I'm just going to plug the phone in, and then we can take the questions. It's fine.
Okay. Rashmi, would you like to start with the first question, please?
Yeah, I think it's very, very interesting to hear all this about an experience, from the staff perspective. And you said there are some green shoots, but order, to really all the recommendation made, and you continue to say we have to produce reports. But if all the actions, recommendation you produce, when are they going to be translate into action? And I mean, if this is the staff experiencing this sort of, in that context, as you put through, I mean, community accessing the services are experiencing similar context. So despite some recognition or some improvement, how do you see that ICB genuinely engaging with the organization locally to implement a race equality action plan?
Did you hear that okay, Felicia?
I do. So that's from an ICB point of view. Do you want to come in, or because I can't answer for the ICB? Yeah, I can't answer for the ICB. I can comment.
Yeah, absolutely. I mean, I think, Rashmi, the work that we've started to do in terms of developing our race health equality plan is to be more transparent about the issues that we need to talk about. So we've had a couple of conversations with our community partners and yourselves. So I think there is something around you holding us to account in that space. So we're being very transparent with the data and the information, and having that space where you're able to contribute to developing that plan more collaboratively and actually challenging us. And I think from the 2 sessions we've had already, that has certainly proven to be beneficial to myself and my colleagues, to actually bring that data to life and just to make sure we're focusing on the real things for you. So I would say, in terms of genuine engagement, I think it is about that face-to-face conversations, being transparent around the problem, sharing the information, and having it as a community activity rather than it being an ICB commissioner activity. I don't know what Felicia's view is.
I've got many things going through my head at the moment. I mean, so in answer to Ms. Shah, I can't see the full names.
Rashmi.
Yeah. Rashmi. I mean, you will know that it's a big problem, and it's never going to be solved very quickly. I always say that, an organisation worth its salt will really focus on this amongst all the other demands that they have. And I think that they're, and those things are, and those things need to be measured. So, the board, especially within the area where your board is, your organisation is it representative of the community it serves? Those are one of the key basic fundamentals, I think, in looking at that. What does your HR disciplinary data show in terms of proportionality in terms of some of the cases? What does your safeguarding principles look like in terms of protection from BME staff, and do they have the right policies, legislation, guidance in place to handle some of these really sticky and wicked issues? Do the staff within the organisation feel that, you know, that the corporate team engages with them, that they can speak up, they can do all of those things? And what does your res show? And is there year on improvement? Those are the things that would signal to me that an organisation has got a grip of the race equity issues, that they are committed to that they are honest and open about what the problems are, and they've got really good tangible actions for improvement. So there's no magic wand to this. There are some organisations across the country that have done this really, really well. But we know, for example, in ICB boards, in terms of having a chief nurse or a chair of a BME background, that's even very poor. The system outside of these ICBs is poor in terms of representation. So, you know, there is no magic wand. I did say there's green shoots, because there are, but it's Rashmi, it's really small. It's not enough. It's absolutely not enough. And I always think with the issue around race, because it calls into question your own ethical compass and moral compass, that's what it does really. And it also calls into question the power dynamics, because a number of our boards and organisations, and I'll just say it, they're very white, heavily white, corporate dominated. They are. And in order to get the equity right, we've got to shift the power dynamics. And some of that is incumbent on some of that is letting our white colleagues let us in, getting the issues around equity and sharing the power space. Yeah, we've got to be able to share it. And for those of us who have got mandates, is to be able to, you know, harness those particular networks and get in there, yeah, and get in there and help to improve the representation. So I don't have a magic wand for you. I'm only two. I'm two heads of nursing within my organisation. Only two, yeah, only two out of what, nearly 7,000 nursing staff. I'm only two of us at the highest grade. We don't have it right in my organisation. We've got, you know, they're trying, but we don't have it right at all. So, you know, and remember, we've got the Equality Act, Rashmi, as well, from 2010. That hasn't, you know, that works in some degree, but this is across judiciary, police, and the NHS as well.
Thank you. Thanks, Felicia. Thank you, Rashmi. Tendai, please.
Thanks, Sharon. Sorry, this is just following up from Rashmi's question. And I suppose my contribution is as a stakeholder in the system that, you know, I'm a beneficiary of good equity, if we all are, right? But I think it starts from a place of accepting that there's a problem. So being very acknowledging, very accepting, just being in that state of discomfort and leaning into that discomfort. We live in a structurally racist society, and accepting that, and the leadership community being prepared to accept that. So I think for me, one of the things that I think will initiate action and change is being unapologetic about taking an anti-racist lens on everything that we do. So holding the ICB to account on what are you doing around anti-racism, because it's a completely different lens to look at the work that's done around race equality. And I think as well, it's also about people taking personal responsibility. It is very uncomfortable work. Leaders at every level, whatever that you define a leader to be, has to be prepared to be questioned, to think differently, to accept that actually the way I'm looking at it from it has a white supremacist lens on it. And I think if we can get to that place, the action will follow, but the mindset has to shift.
Thank you, Tendai. And Felicia, what in your experience of working with ICB boards, organisational boards, what advice would you give in terms of that very senior, accountable, inclusive leadership? Because that's an area where we still need to progress further across the whole of the ICN, not just the ICB. How would you, what would your advice be in your experience in that regard?
So I'm from the acute sector, so so I don't have that much experience, Sharon, with ICBs. I do have experience with some boards, and I find that, you know, really good boards are open and they're accessible. We understand that they have the mandate to make sure that from a governance point of view, the organisation runs well. But you can also get the openness and the transparentness done well as well. And I think one of the things is making sure that you are accessible to, even if it's whatever your monthly engagement webinar with your employees, is to be really, really accessible and open to staff so that they can see you, and that there's a platform for them to raise with the execs some really salient points. I think that's one of the first ones. I think second is, it's good opportunity for some of the execs to spend time in those areas where people work, and to understand what it's like for a BME person, how we walk, what's it like to work in our shoes. Yeah, what's it like? We know, for example, that the racism issue from some patients is becoming worse. The violence and aggression is becoming worse if you are a member of minority background. So what's it like to walk in our shoes? How do you really engage your staff, and how do you understand what they're going through, and then what are you going to do about it? I think it's really important. I think having a good, effective race or BME network is important, with good, strong executive representation on that network as well, who can take things to the board on behalf of the network is really important. So whether it's disproportionate disciplinaries, or whether it's racism, I think that's really important as well. And I think one of the key things, especially the learning from the employment tribunal, is around what's I going to say? It's around, what is your history around HR cases and disciplinaries? Are you seeing patterns? Are you taking the lessons learned for some of these really key reports that are coming out? I would say so. And I think sometimes, Sharon, boards are a bit scared and a bit fearful of doing some things that they think will cause them harm. Okay, yet the organisations have lots of walking wounded, and yet the board is afraid of reputational risk. Yet you've got walking wounded employees trying to give really good care to patients and their relatives, and yet they're wounded. Doesn't make sense to me. The business case for making sure that your staff are well cared for, as and in this aspect, BME staff, great care. If you give great care to your staff, you nurture them, they'll give fantastic care to your patients and your loved ones. It's a no-brainer. Professor Michael West clearly said that the barometer of good patient experience for patients and organisations is the condition, the treatment, and the health and well-being of BME staff. It's very clear out there. So the business case is out there. So those would be some of my and I think it and we're talking about action, aren't we? Race equality week. So how, so what are you doing? How do you act in response to some of the things that staff are telling you? And if you as a board can demonstrate that you are responsive and you act that makes lives of employees much better, even in difficulties. We're not saying it's a magic wand, you can fix everything, but some key elements, then you build trust, don't you? You build trust, and your organisation becomes safer. So those are the things I would say.
Thank you. Diana,
and
would you?
Aaron,
You got?
Sorry. The last thing I would say is representation matters. So lots of boards and organisations can talk about and assume that they are committed to EDI and race equity, and the board looks the same, whether it's race, gender, that your senior staff, clinical staff looks the same, okay, and there's no representation amongst everything else, because sometimes you have the argument, we're just putting people in there. As BME people, we've got triple the education, triple education qualifications, because that's what we are wired to do, and yet it doesn't reflect in career progression and career escalation. So representation matters. There's talent amongst your organization. Make sure it's representative. That's what I would say. That's a real barometer, really.
Yeah. Thank you. Diana, do you have a question, or are you representing others' questions from the chat?
I am representing someone.
Thank you.
Can I just ask, Felicia, but thank you for that presentation. Now, we hear there's a lot of talk around inclusive recruitment, whatever that means, and having diverse panels for interviews. In your opinion, how effective is a diverse panel? Some people say there's no evidence that it really works. Some people say it does work. But in your experience at national level, does a diverse, inclusive recruitment panel work?
Yes, yeah, I would say it does. Now, there is evidence. There is evidence in some organisations that when you have a diverse panel, you can. So you look at the Harvard Business Review. It's very clear. Diverse organisations, diverse appointments improve the performance of that organisation. It's very clearly categorised. What we're talking about when we talk about diversity: gender, race, age, sexuality. We're talking about a whole range of things. In this case, we're talking about race equity because it's the hardest nut to crack. Yeah, absolutely the hardest nut to crack. And I have experience of it. And we have lots of anecdotal evidence. So, I mean, I think that's a research piece in itself. But we know that I have colleagues when they've sat on panels, they know that if they weren't on that panel, okay, that on some occasions the BME candidate is the best person on that panel, absolutely without a doubt. Okay, the BME person is the right one, and that's even on judging panels from recognition and awards. So I just widen it a bit. And if they weren't there, they are very confident that that person wouldn't have been appointed because they would have chosen, for example, the white colleague. They're very clear about that. And there is something about having diverse panels means that there's diversity of thinking, there's diversity of perspective, okay, and there's a sense that there can also be a sense of justice, okay, about doing the right thing, okay. So even though you may have internal bias, having a diverse panel means that that you can you can try and get the justice piece right within your panel as well by doing the right thing and appointing the person that's met the criteria for the job, not based on any color or gender or sexuality, but who's going to do the best job, who's interviewed the best way. And unfortunately, doing the panel interviews is the kind of the gold standard. We know that there's been research on psychometric tests that BME folk don't do well in psychometric tests. We don't do so. We have to be in front of the panels. So I think it's really important to have that diversity. Otherwise, it's groupthink, okay? And if it's groupthink, they think the same way all the time. And when somebody else comes in that's different, it can be a bit of a threat to that groupthink. So they're not going to appoint that person, or they're going to say you're the wrong fit, or some of your views are a bit pushy. So we don't think that you have the right kind of characteristic. So it's important. And I'll say something. For example, in my division, we are predominantly from a BME background. Yeah, predominantly from a BME background. So and some of our senior staff are from a BME background. So I do the opposite as well. Because we're predominantly BME, I always make sure that we might have a white colleague on our panel as well. It can work both ways. So when you have, because it's 80% BME, so we work both ways, and I'm conscious of that both way thinking. And in my division, we have diverse medical consultants, we have diverse representation in the leadership of nursing and midwives. So there's nobody that can say in our division that they can't see themselves amongst the senior tier, but that's just one division. That needs to be replicated across all the divisions within organizations. So I think it's really important. And you should question it as well. So you should question it if it's, where, if it is uniform, people should be able to question that and feel safe to question that as well.
Thank you. Diana, we've got a couple of minutes left. So are there any other questions there that you were going to put to Felicia or anything in the chat?
Diana, in the chat, Somebody has asked about, remember the graph I showed about 3 times more COVID death if you are from a BME background. So somebody has asked that in the chat box. And so some of the evidence is a bit inconclusive on that. But what the thinking is that that it's about health inequality. So we know that in marginalized communities, health provision, health services are very variable or very scarce. And so we know that, and we know that a lot of people live with long-term conditions, lots and lots of people in the population. So in normal times, you probably can cope with those long-term conditions in normal times, going to see your GP, or not accessing your GP, especially if you feel that you're talking to people that don't look like you, or it's a gender or a religion or a race thing. So the thinking is especially that what COVID did was kind of amplify and highlight those health inequalities at a time and a space where people wouldn't have been so vulnerable, that they would have just continued living their life. And I have to say, even at work, one of the surprising things for me is that you discovered that a lot of staff, they have conditions that you would never ever know, because they just get on with their life, they come to work and they do what they're meant to do. As soon as COVID hit, some of those fragilities in people's health were really exposed, because this was something new. Although it predominantly affected your chest, it affected a lot of, it just made you really, really fragile. And that's what some of the thinking is around existing health inequalities were exposed. And for those that had long-term conditions, the COVID-19 vaccine kind of tipped them over into into a space of fragile health. So that's some of the thinking. Thank you, Aidan. Thank you. Yeah, I'm happy. I'll share some of the links. Yeah, so I can share some of the findings on the health inequalities. And Public Health England produced a lot of reports around the variable health inequalities during the COVID-19. I'm happy to send those links through. That's fine.
Lovely, thank you. I'm just conscious of time and that people might need to get off at 2 o'clock. But Miranda, have you got some closing remarks or a question? Happy to take it.
It's just about accountability, because I'm just pulling this from the slide of questions. I think most of them have been answered, but there's a question around how were organizations held accountable for racist behaviors in COVID-19, e.g. sending staff without PPE.
Well, they weren't held very well to account. Okay, that's what I would say. They weren't. And some of the issues around sending staff into COVID-19 areas, if you're an organisation that staff could speak up about that was really good. But lots of staff couldn't speak up about those issues at all. And I think what the National COVID Inquiry is about is uncovering and bringing to the fore those experiences. And I think once we have the final outputs of the COVID inquiry, hopefully we'll be able to grasp some of those elements, and then what do we do next around some of those experiences for staff. So that's it. I would say that's the short answer, is that we're still learning now, aren't we, Miranda? We're still learning now, but there's lots of issues where organisations weren't held to account.
Thank you.
You're welcome.
Thank you. Thanks, Miranda. Okay, we're just a little bit over time, but I will acknowledge all of the questions that we've had through the 3 different forums, and I think Diana will review those, gather those up, and we'll find a way of engaging with people, sending them round, sharing some of the things you've offered to pass through us, Felicia. That would be great, including the slides. We've got 3 more slides here that just enable people to still ask questions and put any thoughts through to us. If anyone needs any further support, there's also a slide here. If anything in the slides today were a trigger for anybody, please do use the support that is available to all our staff. And we talk about the ICB, but this has very much been an ICN, a system event and support. So it's wider than just the ICB. But personally, I just want to thank you all for sharing your experiences, your questions, engaging with the session. A huge thanks to Felicia for joining us just before bedtime, probably, in Australia. We do lots of applause there. We really, really do appreciate you still leading our webinar today whilst you are on your visit. It's been very thought-provoking for me in terms of my commitment and action. I will take actions in terms of my links to my board and my colleagues, because there's been clear themes that have come in through that. So that is the action that I pledge to as well. But I think, as you said, the improvements are small. They need to be bigger. There is much more work to do. And I thank you for inspiring us today. And I will continue to work with colleagues on our patch and beyond to work on this space and this agenda, Felicia. So that's my personal commitment to you all. Do you have any final remarks, Felicia?
No, I mean, I would say that, no, I would say, you know, we have to, within this, we just have to take care of people that finding this a real heavy burden. Just to come into work every day is a constant battle. So I think, you know, we do need to take care of people. We need to, in all of this, we still need to stay positive. Okay, they're small increments. They're still small, but we need to stay positive. And I also think there's strength in numbers. So this stuff is not to be done on your own. Can't be done on your own. You need to be able to find out where your power networks are. You know, develop cohorts. You know, speak out. And I think one of the big things is about, you know, we often say about speaking up and speaking out. That can come at cost. And I would say for everyone in this space, you know, you have to weigh the cost. You weigh the cost of speaking up and speaking out. And will that keep you in your job? Or do you have an organization that recognizes that and will support you in that speaking up? Or if you speak up, will you lose your job? I've been in that situation. Many of us have been in this situation. We don't get to these levels without some pain and some suffering. But sometimes the cost is worth that. So we remember to weigh the cost. And if the place is toxic, it's full of corporate psychopaths, get out. Okay, you can stay in battle sometimes, but if the cost to you is too heavy and it's, you know, just move away from that organization. It's really important. Go where you're celebrated, not where you're tolerated. So that's what I would say. Okay, so the cost thing, you do need to weigh up really carefully and just reach out. I'm happy for you to reach out to me. And I also think, Sharon, I would say this is that the board, that thing about people need to be able to come to the board. It's really important that they come to the board. The board understand what happens on the ground. And if you don't tell them, then, they can make some conclusions that they think are right. And some of it might be, but some of it may not be. So use all those different aspects. And I would say, especially from a BME Black person, is to read. Know the legislation, know the policies within the organisation, what's happening outside of the sector as well that you can use to influence as well. So those things I think are really important. And, it's a battle. We just have to be clear about that. It's a battle, but we need to shift that power dynamic.
Yeah, absolutely. Absolutely. Thank you. Thank you, Felicia. Thank you, everyone. Sadly, I'm going to draw the session to a close. Would have enjoyed it all afternoon, but I wish you all well. And we have a further event that we will publicise on the 11th of February. So just to give colleagues another opportunity to come together and let's talk with some of our staff. And Diana will publicise that. And I would encourage as many of you as possible to join that session, please, so we can continue this conversation and the work we need to do. Thank you all. Have a good evening. Have a good afternoon, wherever you are. Thank you.
Thanks, Felicia. Bye.
Thanks, Felicia.
Bye.